Aboriginal people are experiencing acute, intersecting health emergencies driven by long-standing inequities, infectious disease burdens, and climate-exacerbated conditions. These have placed pressure on ACCHOs and communities. With primary care sites drained in crises, place-based services are playing a central role in response. Our research found out that Aboriginal and Torres Strait Island children already carry among the highest global burdens of otitis media and hearing loss. The burden is heaviest in remote communities of the Northern Territory, where the historical prevalence of otitis media among indigenous children in these areas is approximately 90%. Routine clinical data indicate that many children require treatment or follow-up for otitis media. However, only 57% of children undergo at least a one-year examination every 6 months, and routine systems show poor documentation of examination results or follow-up. This indicates that Aboriginal children lack access to health care.
Through more extensive research, we have discovered that otitis media is highly prevalent among all Aboriginal children in Australia, with particularly several instances in remote areas of the North Territory. Data from urban birth cohorts indicate that the incidence of otitis media is also high among Aboriginal infants, with nearly 45% of affected infants under 1 year of age experience hearing loss. This condition has become a significant public health issue that cannot be ignored. As the research progressed, we gradually discovered that otitis media was merely a symptom of a deeper problem, revealing systematic deficiencies in both the daily hygiene conditions and the healthcare service available to indigenous communities. We selected Maningrida as the community for our research, as it was repeatedly referenced in the North Territory government's official report on this emergency.
We have conducted a meteorological analysis of the community. The Maningrida region experiences persistently high temperatures and humidity, with increasingly erratic rainfall patterns. Extreme weather events such as torrential downpours and tropical cyclones are occurring with growing frequency. Rising sea levels, storm surges, and saltwater intrusion caused by extreme weather threaten coastal communities, damaging infrastructure such as roads, clinics, and water supply systems, thereby disrupting the normal functioning of health services. Extreme weather disrupts the transportation of medicines, vaccines, and medical equipment. Damaged roads delay the delivery of supplies, directly impacting patient care and public health. This situation is particularly severe for patients requiring regular medical follow-ups.
Next, we analyzed the geographical conditions of the region. Maningrida is a coastal Aboriginal community situated on the north coast of Arnhem Land at the mouth of the Liverpool River. The terrain is predominantly low-lying, with the settlement area lying at an elevation of approximately 20 to 30 meters above sea level. Flooding and high humidity also heighten the risk of waterborne and vector-borne disease, while complicating sanitation maintenance and clear water supply efforts. In addition, we researched the history and the governance of the region.
Resident analysis is a key focus of our research. Maningrida is among the most linguistically diverse communities in the world, home to 15 distinct indigenous languages. Most Aboriginal residents are multilingual, typically speaking at least 3 languages, reflecting a vibrant intercultural exchange. This community exemplifies contemporary Australian cultural resilience, and adaptability. Despite the profound challenges posed by colonization, modernization, and globalization, Maningrida has sustained a rich multilingual environment, traditional cultural practices, and a deep spiritual connection to the land, while simultaneously fostering innovative educational models, driving economic development, and safeguarding cultural heritage. From the perspective of cultural values, residents possess deep-rooted traditions centered on kinship, language, land, spiritual beliefs, and community life. In terms of spirituality, belief systems in Maningrida region are grounded in the concept of the dreaming, the yawn, and wanga, which refers to the ancestral era when spiritual beings shaped the world, established laws, and endowed people with identity, language, and land. The political background of residents in the Maningrida region is shaped by a unique mix of traditional indigenous governance, changing government policies, and ongoing advocacy for community self-determination, often impacted by external decision-making and historical tensions between indigenous and non-indigenous populations. The community's linguistic, cultural, spiritual, and political diversity presents significant challenges to the delivery of the healthcare and other social services. Maningrida, with only a few thousand residents, is home to 5 different indigenous languages, yet only 16.5% of the population speaks English. Unlike many other communities, Maningrida lacks a single lingua franca among its various language groups. As healthcare providers primarily communicate in English, linguistic differences substantially hinder medical effectiveness. Studies indicate that patients comprehend only about 50% of what English-speaking practitioners convey. Without interpreter assistance, essential medical information, often described as potentially life-saving, cannot be effectively communicated to patients. Communication barriers are particularly detrimental to child health care, as effective care depends on clear interactions with families. The involvement of language and cultural workers has considerably improved service delivery in child health programs. However, access to systematic interpreter support remains limited. From a cognitive perspective, Aboriginal children tend to tolerate ear pain more readily than non-Indigenous children, who often perceive it as an alarm signal. This difference makes otitis media more difficult to detect among Aboriginal children. Additionally, many parents do not fully understand the nature of the disease, treatment, instructions, or the importance of follow-up care, nor do they consistently communicate symptoms, prevention, and treatment information to their children. As a result, preventable and treatable conditions such as otitis media are frequently overlooked or left untreated, leading to chronic infections, hearing loss, and long-term developmental and educational disadvantages. Culturally, many Aboriginal residents experience mistrust and a sense of disempowerment towards a modern healthcare system, which often neglects indigenous beliefs, kinship structures, and communication styles. When indigenous interpreters are involved, trust and patient satisfaction increase significantly. Nevertheless, systemic shortcomings such as incomplete documentation of language needs and underutilization of interpreters continue to create inequities in healthcare delivery. Historically, enduring legacies of colonization, discriminatory policies, and culturally insensitive medical services in Maningrida region have deepened indigenous mistrust of mainstream healthcare. At the systemic level, inadequate cultural safety contributes to misunderstandings of consent forms, missed appointments, and premature discharge. These institutional failures result in poor patient engagement, ineffective treatment, and worsening health outcomes. Over time, these interrelated factors have produced a persistent circle of health disadvantage.
We have also analyzed several outstanding precedents. This is an artificial intelligence-assisted healthcare service initially jointly established by the North Territory Government and Charles Darwin University. The project emphasizes co-design, involving health care agencies, communities, patients, and frontline healthcare staff in collaborative participation, varying all contributors. The project addressed the challenge of understanding and tracking otitis media and hearing loss clusters in remote North Territory communities by revealing their correlation with specific social determinants like housing, healthcare access, and education. Use AI-powered geospatial analysis. Through AI-driven geospatial analysis, high-resolution community data, integration of social and environmental determinants, interactive mapping, data-driven policy recommendations, and future adaptability safeguard by data updates and version control. The anticipated outcome of the project include interactive system identifies high-risk area, guides police makers and providers, targeted resources allocation, reduces disproportionate impacts, links to social determinants, transforms service delivery, and supports remote indigenous communities.
We have thoroughly studied and drawn upon the exemplary indigenous community healthcare practices of the Maningrida Alina Primary Health Center. Particular emphasis has been placed on analyzing the frameworks and areas employed in its provision of healthcare services to indigenous populations. The Maningrida Alina Primary Health Center is a community-operated primary healthcare facility located in Maningrida, managed and faced by the Malala Indigenous Health Service. The center prioritizes employing local Aboriginal people as frontline workers or interpreters, demonstrating full respect for the emotional needs and cultural identity of Aboriginal patients. The center provides comprehensive primary healthcare services, maintains a 24-hour emergency function outside working hours, and delivers mobile healthcare services to surrounding indigenous communities. As a healthcare facility serving a remote community, it handles an exceptionally high volume of patient attendances. Firstly, it emphasizes community control and self-determination, forming a robust structural foundation. Community control is a center to culturally appropriate services, as it centers local decision-making, language, and prioritizes. By referencing existential evidence and national policy prioritizes, it enhances the accessibility, trustworthiness, and the relevance of care. Existential is the Aboriginal community-controlled health organization model. Secondly, it prioritizes cultural safety, requiring organizational commitment, reflective practice, indigenous workforce representation, and systems to measure cultural safety outcomes, not merely one-off training. Thirdly, it emphasizes humanistic, person-centered care, prioritizing dignity, relational care, partnership, and viewing individuals beyond their illness, aligning with indigenous holistic SEWB, which means where family, country, and culture form the core of well-being. Finally, it values trauma-informed practice, which is crucial in remote indigenous settings. Historical and intergenerational trauma particularly impacts service engagement. Trauma-informed approaches reduce re-traumatization and build trust.
To study otitis media as a public health care emergency, one must examine its pathology. Our research found that otitis media prevalent among young children is not merely a simple ear infection. Its pathogenesis is relatively complex. Otitis media, common among young children, typically arises from viral upper respiratory tract infections. Edema of the nasopharyngeal mucosa and dysfunction of the eustachian tube facilitate the entry of bacteria into the middle ear, where bacterial pathogens proliferate and induce inflammation. This provides new insights for our subsequent design of medical services aimed at preventing otitis media. We also investigated the treatment for both acute and chronic otitis media. Current mainstream therapies include pain management, oral antibiotics, and topical antibiotic applications.
The etiology of otitis media involves not only microbial factors, but also socio-environmental factors. Existing evidence indicates that common ear pathogens interact with household and societal risk factors, increasing infection frequency and contributing to chronicity. Children's weaker immune systems, overcrowded living conditions, indoor smoking, and inadequate access to healthcare have all contributed to the widespread prevalence of this disease. We have also conducted a detailed analysis of the systematic challenges currently facing healthcare services in remote areas of the Northern Territory, including historic legacies fostering indigenous people's apprehension and distrust towards modern healthcare, cultural and linguistic barriers between indigenous communities and healthcare practitioners, obstacles to accessing medical services encompassing transport difficulties, accommodation challenges, and complex referral procedures, inadequate infrastructure, and insufficient integration of digital and telemedicine solutions. I am Amy. From the perspective of service and interaction design, I have identified some opportunities and come up with a few strategies. Many communities face transportation barriers, limited communication channels, and uncertainties like weather or coordination issues that disrupt continuity of care. To address this, our strategies focus on reducing uncertainty by centralizing time and processes, and using low-threshold, culturally appropriate interactions to make health information more accessible for all community members.
I will approach this project from the perspective of product design to support indigenous children and their families. Drawing inspiration from the art and cultural heritage of the Maningrida Aboriginal community, I will incorporate design elements that embody humanistic care and deep respect for indigenous cultural values. The goal is to create culturally sensitive design solutions and healthcare service processes that acknowledge and respond to the psychological needs and concerns of the indigenous children and their families. From the standpoint of product morphology, I will focus on design details that make medical devices appear approachable rather than clinical and intimidating, fostering trust and comfort among children and their families. At the same time, I will prioritize environmental sustainability and harmony between people and nature through careful consideration of materials and craftsmanship, striving for country-centered design.
Based on my research in this village, I discovered that design cannot be confined to the design itself. Instead, it must be grounded in a comprehensive consideration of local culture, geography, and developmental conditions. Only by first establishing respect for the indigenous people and then design according to these various factors can the ultimate requirement of the design be met. Place greater emphasis on the emotional and familial bonds of indigenous peoples, and increase the number of indigenous interpreters and caregivers.
Thank you for your listening, and I look forward to your questions.